You're listening to Conferences Online Allergy from Children's Mercy Hospital in Kansas City, Missouri. Today is July 28th, 2025. We are doing our orientation series, and our topic today is the management of anaphylaxis. This is presented by Dr. Arti Pandya. She is an associate professor of pediatrics and is the medical director of the Food Allergy Center at Children's Mercy Hospital in Kansas City, Missouri.
Morning, everybody. My name is Arti Pandya. I am Assistant Professor of Pediatrics here at Children's Mercy, Medical Director of our Food Allergy Center, as well as at the University of Missouri, Kansas City. We are doing our starter series of the COLA orientation series. This morning, we will start with talking about anaphylaxis. All right. Here are the relevant disclosures for this topic. Being a speaker for Sanofi Regeneron, grant with Thermo Fisher, and writer of the practice parameter revisions for immunotherapy. So objectives, apologize this didn't come through here. We will be talking about the diagnosis and management of anaphylaxis, testing related to anaphylaxis, and differential for anaphylaxis. The definition for anaphylaxis here is going to be an acute, potentially life-threatening systemic hypersensitivity reaction caused by sudden onset release of mast cell mediators. And this most often results from an IgE-mediated mechanism. When it does result from an IgE-mediated mechanism, we're talking about foods, medications, insect stings being common causes. But it should be notable here that any agent is capable of inciting a sudden systemic degranulation of mast cells to induce an episode of anaphylaxis. The clinical criteria for diagnosing anaphylaxis, there's been a couple, of course, that we have seen throughout our literature, but in general, these are what we commonly adopt for diagnosis of this particular disease. So there's one of three conditions here that we can meet. The number one is acute onset of illness involving skin, mucosal tissue, plus one of the following, which includes respiratory compromise or cardiovascular compromise here, including reduced blood pressure, associated symptoms like hypotonia, presyncope, syncope, incontinence. The second condition that could be met is rapid onset to an allergen for a patient where you can have either involvement of cutaneous tissue, respiratory involvement, cardiovascular involvement, or gastrointestinal involvement. The third condition could be a reduced blood pressure or hypotension after exposure to a known allergen. And then there are different conditions here for infants and children compared to adults. So if any one of these three conditions are met, certainly we are thinking about the diagnosis of anaphylaxis. In terms of the incidence of anaphylaxis, the exact incidence cannot be established based on available data. Most studies do indicate a significant underreporting. We do know that while anaphylaxis can be fatal, the majority of anaphylaxis is actually self-resolving, which likely leads to the underreporting. Foods are one of the most common triggers, followed by medications. Drugs are most commonly causing anaphylaxis with nonsteroidals as well as antibiotics. Perioperative anaphylaxis is a recognized offender as well. And then the overall incidence of anaphylaxis related to latex has greatly diminished as well. The diagnosis and treatment of anaphylaxis can be challenging. We do know that while the incidence is not exactly reported, there are studies to show that the incidence is increasing. Mortality risk from anaphylaxis is increased in asthmatic patients, teenagers, and elderly patients with comorbid conditions. And evaluation of a specific patient requires an understanding of possible exogenous triggers, medications, as well as endogenous factors such as conditions that can increase your risk, including mast cell-related diseases. So our pathophysiology mechanisms for anaphylaxis can include having IgE-dependent mechanisms. And so with that, these are the most common offenders here: food, drugs, Hymenoptera venom, exercise, or IgE-independent mechanisms, which can be IgG-mediated, complement-mediated, and then non-immunologic can include our receptor-mediated mechanism, which is MRGPRX2, a receptor on mast cells that can result in direct degranulation of the mast cells. An example of an agent that can do so would be opiate medications, but there are many medications that can do it, as well as other like radiocontrast media could do this as well. And then, of course, there's pathophysiology where multiple mechanisms could be in play, such as mastocytosis, exercise with other cofactors, and then, of course, we also have idiopathic anaphylaxis. The pathways that get activated during anaphylaxis, of course, our major one here particularly is going to be mast cell activation, whether that be through an IgE or non-IgE mediated mechanism. Once mast cell activation occurs, you can have a release of multiple mediators here, including histamine, protease, tryptases, and then subsequently the release of these mediators can result in recruitment of additional cells. You can also have lipid metabolites released, leukotrienes released, as well as prostaglandins, platelet activation factor. Subsequently, you have involvement of your coagulation pathway, complement cascade, your kallikrein kinin contact system, and then platelet activation as well. What about anaphylactic shock or shock resulting from anaphylaxis? As you remember, this is one of the causes, this can be a cause of shock. And so what are the mechanisms that have been evaluated or looked at here? So the commonly or clearly demonstrated mechanism here is when you have fluid extravasation. This causes hemoconcentration, hypovolemia, reduced venous return, and ultimately reduced cardiac output. So that's one of the major things for us to remember here. And then likely additional mechanisms that are in play include venodilation and blood pooling. This contributes to reduced venous return, impaired myocardial contractility, again resulting in reduced venous return and reduced cardiac output, relative bradycardia, early transient increase in pulmonary vascular resistance, and then early arteriolar dilation. So all of these can play a role here likely playing a role here. And some postulated or uncommon mechanisms for us to think about include global depression of myocardial contractility, severe arteriolar dilation, and then coronary ischemia as well. So all of these things are, for us to take into consideration, but the one that's listed here as commonly or clearly demonstrated is going to be the major driving factor when anaphylaxis does contribute to shock, or does result in shock. All right, what factors affect the incidence as well as the severity of anaphylaxis? First is geographic location. So the incidence of anaphylaxis may be increased with altitude, with less ambient sun. Maybe there's some protective role of vitamin D that has been postulated here as well. Socioeconomic status has been shown to have a consistent relationship to the incidence of anaphylaxis as well. Race and ethnicity have not demonstrated a clear effect in the literature. Age, in terms of contributing to the incidence and severity of anaphylaxis, we know that anaphylaxis with foods is more common in young children, and then the diagnosis of anaphylaxis is more difficult in infants as well. In terms of gender, so overall males are more affected, especially under the age of 15, and then females are more affected after the age of 15. Venom-induced anaphylaxis appears to be more common in male patients as well. And then atopy is a clear risk factor for food-induced anaphylaxis, not clear with other stimuli. Poorly controlled asthma is a clear risk factor for adverse outcomes that come from anaphylaxis. Mast cell-related disease are a clear risk factor for anaphylaxis. The route of administration of medications with medications being through the oral route are less likely to produce anaphylaxis compared by the parenteral route. Gaps in administration predisposing to reactions of constancy of administration could be a contributing factor here. And then time since the last reaction could be a variable that we need to think about as well. Okay, So when we are thinking about the mechanism, the pathophysiology, now we get to the point where we're at mediator release. So what happens from mediator release? We can see that histamine is a pretty potent mediator here that can result in multi-system involvement, including your respiratory system, your GI system, your cardiovascular system, as well as your cutaneous system. You have the contribution of anaphylatoxins, platelet activating factors, cysteinoleucotrienes, especially on skin, as well as the respiratory system and the cardiovascular system as well. So lots of different mediators, like lots of different cytokines, chemokines that are contributing here that ultimately result in your multi-system involvement with anaphylaxis. What about the incidence for common triggers of anaphylaxis? So when we do an evaluation of anaphylaxis in the clinic, of course, we're going to take a good history on all of those things that I mentioned in the earlier slides, especially taking a good history on symptoms, time of onset from exposure to symptoms, as well as the degree of involvement that happened in that particular episode. Did they seek medical treatment? What were they treated with? All of those things we're going to take a good history on. And if we do find a cause, it's going to likely fall under this, chart in terms of finding a cause. Of course, you can also fall into the realm of idiopathic anaphylaxis, where you do have to evaluate for underlying conditions as well. So knowing that, when we talk about antibiotics here, antibiotics are arguably the most common cause of drug-induced anaphylaxis, most frequently with beta-lactam agents. In terms of latex, we talked about in general, it's not absent, but the incidence of latex-induced anaphylaxis has been decreasing. Perioperative anaphylaxis can contribute to 9 to 19% as complications from anesthesia. There is a fatality rate here of 5 to 7% that is recorded. Muscle relaxants do contribute from the majority. We also think about antibiotics here as well, though, as that is a common agent that is administered when an individual does have perioperative anaphylaxis. What about radiocontrast media? Here, there's a frequency of about 4 to 12% with non-ionic, and then severe reactions may occur in 0.16% of ionic media as well. So another thing to kind of think about. Hymenopterous stings. So these are potentially, life-threatening systemic reactions, and the incidence here is estimated between 0.4 and 0.8% of children and 3% of adults. And then with regards to food-induced anaphylaxis, as many as 6% of children that could affect, or 4% of adults. So, and we talked about this a little bit when we did our food allergy lecture as well. Incidence with nonsteroidals has been variable. Anti-sera has been an important cause of anaphylaxis. However, notably, incidence has decreased with this as well. Reactions with hemodialysis have been related. And then lastly, we talked about idiopathic anaphylaxis as well as biologic agents. Okay, what about when you do have anaphylaxis? What is the approximate percentage of system involvement or frequency of occurrence when an episode does happen? So by and large, the cutaneous system is the most commonly or frequently occurring organ that does get involved, within a percentage of about 80 to 90% of frequency. The respiratory system is a close second here with about 70% of cases. So that's why, especially colloquially, when people talk about anaphylaxis, they say, oh, there was hives, but we didn't progress to breathing. Oh, it's not that you can't progress to having these other organ systems being involved. It's just that the frequency of occurrence is the most common in those two systems. Cardiovascular and GI is tied here at 45% between those two. Again, that doesn't mean that those are unlikely to be involved. It just means frequency-wise, it falls less on the chart. And then CNS involvement is going to fall at 15%. So important to remember, especially again, when you're taking that history and asking about the involvement of these different systems as well as symptom occurrence. So we talked about the diagnostic criteria of anaphylaxis. In terms of pictorially, this is another thing that's kind of depicting a sudden onset of illness when you have cutaneous involvement plus either respiratory or cardiovascular involvement, or two or more of these being involved, or in number 3, when you have an inciting event plus you have hypotension that is present. So again, kind of more just pictorially depicting what we had talked about in an earlier slide. What about individual patient factors that increase the risk of anaphylaxis as well as severity and then fatality? So let's talk about age for infants. There is, with infants itself, a high degree of under recognition, under diagnosis, and then with certain weights of patient, which we'll circle back to later in this slide, there can be weight-based dosing that we do, but if we just have availability of epinephrine auto-injectors, there are doses that are available, not available, and then less available. So we'll kind of talk about that in a little bit later slide. And then adolescents and young adults are increased with risk-taking behavior. So we also talked about this in the previous summer series with regards to different things like food allergies. And one practical tip that I can give to all of our new fellows is using callback teaching as an important patient-centered approach when you're having them kind of independently carry their epinephrine auto-injectors, having an understanding of their own diagnosis of anaphylaxis, understanding their own epinephrine auto-injector device, appropriate way to use it, etc. In terms of elderly patients, especially with comorbid conditions, there's an increased risk of fatality from medications, and then venom-triggered anaphylaxis can be fatal in that particular population as well, or more severe, I should say, as well. And then comorbidities play a huge role here, especially asthma and respiratory diseases in general. Uncontrolled asthma is a huge variable for increasing the severity of anaphylaxis and increasing anaphylaxis-related fatalities as well. Cardiovascular disease, mast cell-related disease come in pretty close here. Allergic rhinitis and eczema or atopic dermatitis can be important comorbid conditions that can increase in certain inciting factors for anaphylaxis. Namely, we talked about food allergy being one for that. Depression and other psychiatric disorders may lead to impaired recognition of symptoms, and then thyroid disease as well. How about concurrent use of medications and chemicals? So this can potentially affect recognition of anaphylaxis or increase anaphylaxis severity or blunt the effect of medications that we use to treat anaphylaxis. And then we have various other factors that are listed at the bottom here, including exercise, acute infection, menses, emotional stress, occupation, etc. So all of these are important factors to take into account. So how about risk factors for severe allergic reaction? And what's kind of how do these factors play in from the host and then allergen-related factors? And there is kind of a continuum of how this can happen with the initial allergen presentation, host response, then host behaviors, burden of allergic disease, medications, other host factors, and then the ability to compensate. And so the outcome here could be inadequate or delayed treatment. And we know that delayed use of epinephrine results in lots of adverse outcomes as they pertain to anaphylaxis, as well as contributing to biphasic reactions with anaphylaxis as well. So lots of different factors here that we as clinicians need to take into account when evaluating a patient that has a condition or an inciting factor that could contribute to anaphylaxis, or when they've come to your clinic already experiencing anaphylaxis. In terms of grading the severity of anaphylaxis, there have been multiple proposed grading systems. This is one that's commonly adopted, which uses a 1 to 5 grading system, depending on the severity of the condition. Again, I just want to point out here that there are multiple out there. Please be aware of what your institution uses or adopts. But yeah, there are different grading systems for severity. Okay, so we have a clinical picture now that is consistent with anaphylaxis. What differential should we kind of keep in mind? Even if we are pretty certain here that the clinical picture is consistent with anaphylaxis. So of course, this is the underlying condition is there, but then here we have conditions that can have abnormalities in vasodepressor responses, such as flushing syndromes or autonomic epilepsy. We have food-associated conditions such as rhomboid conditions, effects of sulfite or MSG. We have other forms of shock that could be present. So cardiogenic shock, septic shock, vascular, contribution from other conditions. So neurogenic shock could be another thing to keep in mind. Low output, high output shock, all of those things are things that we need to take into consideration here. Excess endogenous production from the histamine syndromes could be something for us to think about here. So namely our associated mast cell conditions are outlined here. Non-organic diseases is also something for us to think about. And that doesn't mean that those conditions don't have things that require evaluation and treatment for. It just means that that's something we need to think about on the differential. And then miscellaneous, so a common one that we think about is acute urticaria with or without angioedema. And then if respiratory conditions are present, that coupled with potentially having an asthma exacerbation, that's probably the condition that is most difficult to delineate from having anaphylaxis from an inciting, trigger that's ultimately, contributing to your clinical picture. So this is where close history, good diagnostic testing, and good follow-up with your patient is very key and very important. Hereditary angioedema, idiopathic and angioedema, we talked about that quite a bit in our previous summer series lectures. So this terminology has fallen out of favor. I do want to note that here, but involvement of medications, especially with mechanisms like MRGPRX2 involvement, capillary leak syndrome. So all of these things we do want to keep in mind as a differential for anaphylaxis. What about measures to reduce anaphylaxis as well as death from anaphylaxis? So the number one, 2, 3, and 4 treatment measure is going to be to have treatment promptly with intramuscular injection of epinephrine. We also have intranasal now that is available as an option. And there are going to be different modalities that come out onto the market at various points in our future here. But the bottom line is administration of systemic epinephrine without a delay with early signs of anaphylaxis. That's going to be your number 1, 2, 3, and 4 measure that we can take to reduce anaphylaxis, severe outcomes, fatalities from anaphylaxis. All right, what about general interventions? Taking a good thorough history for drug allergy, avoiding drugs that have immunologic or biochemical cross-reactivity, administer drugs orally when you can as opposed to parenterally, checking all things for proper labeling, If immunotherapy is administered, we talked about this previously too, making sure they're kept in the office for 30 minutes after administration, and then following observation for specific drugs when it comes to increased incidence for anaphylaxis. A good example here is omalizumab, and having a 2-hour observation after the first 2 doses of that particular medication. What about measures for patients at risk? So consideration of having warning of identification tags for known agents that can contribute, teaching self-injection for epinephrine, again, using that. So callback teaching I mentioned in the setting of adolescent. Of course, this is a great, way to teach your adult patients as well. So I don't want to discount that here, especially for those of us in fellowship who are seeing a heavy amount of adult patients. And then this topic in terms of, utilization of beta blockers, ACE inhibitors, tricyclic antidepressants, it's a little bit tricky because you can consider discontinuation with your consultant in the appropriate context. But if these are medications that are, life-saving for patients, particularly our cardiovascular patients, or even our, psychiatric patients where they've reached mood stability with regards to these medications, you have to take that into consideration. Of course, I'm not saying that that's a blanket statement. That has to be a very close multidisciplinary discussion that occurs and only in the right patients. And then lastly, appropriate preventative techniques, when possible, should be taken place. An example of this is if we're doing a desensitization procedure or if we're doing a drug challenge, having epinephrine, systemic epinephrine administration readily available in the office. Okay, What about lab results or lab tests that we can obtain? So tryptase is a lab that can be obtained 4 hours out, up to 4 hours after an event of anaphylaxis. The normal range that can be reported is 1 to 11.4. Infants under the age of 6 months with normal baseline tryptase concentrations are higher than with older infants, children, and adults. There is a formula to evaluate tryptase elevation from baseline. So this is one that would add to your kind of different formulas or calculations that we need to take into account. Looking at a study of 141 cases, or 33% of patients, at a mean of 4.75 hours after estimated onset of symptoms with resolution in 23 cases, tryptase was above 12.4 and had a specificity of 88% and a pretty high positive predictive value. However, there was a low sensitivity and negative predictive value. So serum tryptase is more likely to be elevated in patients with hypotension. I think the bottom line here is that it's not an end-all be-all test when it comes to the diagnosis of anaphylaxis. Anaphylaxis is still a clinical diagnosis. Tryptase can be an appropriate supportive test that we can obtain. And if there's elevations in tryptase levels, there is value in getting baseline tryptase levels as well. In terms of tryptase, so there's immature forms of tryptase that can be collected, as well as mature forms of tryptase that can be collected. So in terms of the immature forms, we have alpha protryptase and beta protryptase. These are spontaneously secreted by unstimulated mast cells. And then mature tryptase is proteolytically processed, namely alpha tryptase and then beta tryptase. And so there's some value here in obtaining your mature forms. However, not all labs, this is commercially available. We should note here that in food anaphylaxis, tryptase is less commonly elevated. So again, that goes back to the importance of having anaphylaxis as a clinical diagnosis, having tryptase as a supporting test, but taking that into account in the right context as well. What about the use of histamine, prostaglandins? These are certainly, so there's urinary tests for histamine that are commercially available. There's also serum histamine that is available in research centers, but that's mainly what it is. It's that histamine and prostaglandin, and then there's urinary tests for prostaglandins that are commercially available. And then serum levels for these, are difficult because they require pretty quick collection because they have a very, very, very short half-life. And so outside of the research setting, not a lot of these are done. So going back to that main point here, ultimately this is a clinical diagnosis. Careful history does need to be taken. Identifications of triggers should be considered and obtained through a thorough history, and testing is adjunctive but not needed to confirm a diagnosis. What about the diagnostic evaluation for somebody who's had anaphylaxis? How do I approach that? So first and foremost here, emphasizing my last point, your patient has to have a history that's concerning or consistent with anaphylaxis. After that, we take a detailed history. Is there likely a trigger identified? If so, yes, then you go down that evaluation with that trigger. If there's no likely trigger identified through a thorough history. So I cannot emphasize enough the importance of this. This is where your training through ANI fellowship is going to be so important, because you can see here that this delineates into two different pathways. So if it's no, then you obtain baseline tryptase and you go down this pathway of looking for either conditions that can incite anaphylaxis, incite idiopathic anaphylaxis, or incite anaphylaxis more quickly, I should say, with minimal triggers, or we look at conditions that can mimic anaphylaxis is essentially the route that we're going down. And then if we do identify a trigger, of course, appropriate evaluation for that. But like this point here in this chart is so important, and it seems so simple when you're looking at this chart, but this is really where so much clinical discretion is needed. First line treatment. First, second, and third line of therapy for anaphylaxis is going to be epinephrine. So here I've listed intramuscular and intravenous dosing, but I am going to come back to intranasal dosing a little bit later in the chart. Intramuscular dosing, you're going to have epinephrine at 1 to 1,000, and intravenous dosing is going to be at 1 to 10,000. Lying the patient in a recumbent position, assessing for hypotension, hypoxia, quickly administering supplemental O2, quickly administering IV access and fluids if that condition is met, and then albuterol. So these first 1, 2, 3, 4, 5, 6 here are so crucial for prompt administration in anaphylaxis. I want to note down here that antihistamines, what about that, Dr. Pandya? What is the role for that in anaphylaxis? The answer here is that they're an important measure for symptomatic management, but that's just what it is. We don't want to rely on those medications alone to treat anaphylaxis when it comes to a patient who is presented with this condition. Those first 6 points are they're so important in early intervention for anaphylaxis. All right, so let's talk about this a little bit more thoroughly. So immediate actions that we take, we assess the patient, we check the airway, make sure that's secure, we assess the level of consciousness and vital signs. I mean, those things should happen pretty quickly when you have a clinical suspicion for anaphylaxis. Then pretty quickly after that, we are going to make sure epinephrine is administered. Again, this is an older chart here, so only has epinephrine identified here, but making sure we're in a supine position, legs are elevated, oxygen is administered. And then if you have a known inciting event, like let's say this is happening with allergen immunotherapy, we can promptly make sure a tourniquet is placed proximal to the injection site. Now, our further evaluation and treatment here kind of depends on the trajectory of your patient. If there is hypotension present, to maintain your cardiovascular status, we are going to administer peripheral fluids. Glucagon can be administered, especially if you have a patient with a beta blocker. Even if you do have a patient who is on a beta blocker, your second line of treatment is still going to be epinephrine. And then glucagon can come if you're having an inadequate response to treatment. Antihistamines, again, we talked about the role of that with symptomatic management, vasopressors. Corticosteroids, I am going to circle back to this a little bit later in the presentation, but there's a lot of data here showing now that there's not good data showing that corticosteroids can prevent biphasic anaphylaxis. Well, then what role do they have in anaphylaxis? I think the bigger question here is there a patient here that has concomitant asthma? Is there a concomitant picture of uncontrolled asthma that has been attributed to anaphylaxis developing more quickly where that could have a role here is the bigger question that we need to ask here. And then, of course, atropine, ECG monitoring, transfer to hospital, and then hospital management is listed out here. So what about equipment and medications for office therapy for anaphylaxis? Primarily having epinephrine solution or epinephrine auto-injectors. If you have the solution, making sure you have disposable syringes, tourniquet, oxygen, access to antihistamine, injectable is listed here, but I kind of talked about the role here. Access to setting up IV, large bore catheters, potentially, bronchodilator administration and access, glucagon defibrillator, and then normalcy. Okay, so in terms of intramuscular epinephrine and auto-injector device, there's multiple on the market here. There's some that are going to talk you. Start here in the upper left. So there's some that are going to talk you through, the administration of the medication. So that's largely with this device here. There are some where needles are going to be exposed here. So that's these two devices here. And then with the brand name epinephrine, there is no exposure of the needle. So understanding the nuances of each device, making sure that those are discussed with the patient are very important things to do. Especially in our teenage patients, having a pocket device is something we heavily want to think about for ease of carrying. And then last thing, which I think I'll get to the next slide here before I talk about it. Yeah. So before I go into this whole slide, what are some quick and easy things you can tell patients? Because obviously for us, we are trained in all of these things I'm discussing here. So we're comfortable with knowing and talking about epinephrine and auto-injectors versus pulling up epinephrine in a syringe. But how do we do the quick and dirty with a patient? There's two mnemonics that you can consider teaching your patients. You do not have to use these mnemonics by any means. And I don't know if mnemonic is the the best way to think about this, but I'm actually going to go back to the previous slide here to give you a visual of how to teach this. What about teaching them the diagnosis of anaphylaxis? Are they going to look at a chart every time they have a clinical picture that is suspicious or they've had an accidental exposure? Maybe. Or you can teach them one phrase here, beyond the skin, epi goes in. It's a quick and easy way for us to teach our patients the timing of when to use anaphylaxis when there has been an accidental exposure that has occurred. What about the devices apart from this one? Maybe even this one a little bit. There's another thing you can teach them, which is blue to the sky, orange to the thigh. So in some of these devices, this is going to require removal of the cap and then, pushing down on the auto-injector device into the anterolateral aspect of the thigh. But in terms of how to orient the device so that you don't get epinephrine injected into your thumb or your hand, you can teach them blue to the sky, orange to the thigh, and then that kind of helps them remember those things. So I do teach my patients these, but also just make sure you are, kind of knowing what device the patient is carrying and all of those things as well. Okay, now we're circling back to the dosing of auto-injector devices and intranasal epinephrine. So in terms of auto-injector devices, the 3 doses that are on the market are 0.1 milligrams, 0.15 milligrams, and 0.3 milligrams. And the 0.1 milligrams is FDA dosed at 7.5 kilograms up to 15 kilograms. What about below that? We don't have data on auto-injector devices. It doesn't mean we don't have data on epinephrine dosing. But what you choose to do will be dependent on your level of comfort with the patient. Are you going to send them home with a syringe as well as a needle? And then are you going to calculate the dose based on their weight? Or are you ultimately just going to prescribe them an epinephrine auto-injector? Both are options for us to think about. There's, of course, off-label data here on use of these auto-injector devices on younger, patients of weight less than this. But it's just something to think about in terms of the way that the FDA has labeled these medication doses based on the weight. Okay, so 7.5 to 15 kilograms, again, we've talked about 0.1 milligrams, but for a 12.5 kilogram patient, the 0.1 delivers only 80% of the intended or ideal dose. The 0.15 milligram dosing delivers 120% of the ideal dose. So let's talk about that further here. So again, this is the FDA advertised dose for 15 to 30 kilograms. However, in patients who are 20 kilograms, about roughly 44 pounds, the 0.15 milligram device only delivers 75% of the intended dose or ideal dose, whereas the 0.3 delivers 150%. And for a 25 kilogram patient, the 0.15 milligram device only delivers 60%, whereas the 0.3 milligram delivers 120% of the ideal dose. What does that mean? What do we do for those patients? I think it depends, and I think this is where the art of practice comes a little bit into play. If you feel comfortable with the higher delivery amount, you can of course consider prescribing the higher delivery devices. Well, what if insurance doesn't cover them? Fair point. Are you going to have them administer both at once? If you have a 25 kilogram patient with 2.15 devices, you could, but then you're out of devices. So this is where a little bit of nuance comes into play. I highly recommend making sure you have a great discussion with your attendings about this, because our personal practices are all going to vary based on what you're seeing up here. But that's where some art of practice does come into play. Okay, what about intranasal epinephrine? For 15 to 30 milligram or 30 kilogram patients, the 1 milligram spray in one nostril is available, and 30 kilograms or higher, it's a 2 milligram spray that is available. Again, one of the newer kids on the block. Okay. Likelihood of needing epinephrine in terms of those who have been prescribed epinephrine autoinjectors. So these conditions have been outlined here in terms of, well, does any drug allergy patient need to have a epinephrine autoinjector device carried, or does any patient with oral allergy syndrome need to have an epinephrine autoinjector, or does any patient with IgE-mediated food allergy? And then what about aeroallergen immunotherapy? So this is where there's some variability in the likelihood of requiring treatment with epinephrine autoinjector. Again, I think this is one of those table kind of snapshot and carry with us to get an idea of who needs to carry an epinephrine autoinjector with baseline conditions. Okay, and I think we've emphasized this a couple times here, but see the importance of it by the amount of times I've talked about it in the talk here. For risk factors or severe fatal anaphylaxis, there's different risk factors here for drug-induced, food-induced, venom-induced, and then ones where there are no triggers. Take that into account with all of these individual patients. Okay, another topic with, I don't want to say controversy, but some spirited discussion that can take place. What do we do once a patient has been administered epinephrine in terms of calling EMS? So here is some recommendations that have come from Dr. Golden's latest paper here in the Annals of Allergy, Asthma, Immunology. So home observation following the first dose. Here we have signs and symptoms that emerged prior to epinephrine administration, resolved within minutes of epinephrine administration. The patient is asymptomatic, they have scattered or residual hives, they could even have new emerging hives, but overall there's a high degree of clinical stability here. Consider home observation as opposed to calling up EMS. Okay, when should I consider EMS activation? So there's a second dose of epinephrine administered, but let's see what they recommend here. So they had signs and symptoms that observed with prior to the first dose of epinephrine, it improved or resolved. Then there was a persistence of some other symptom here, like a globus sensation, nausea, coughing, stomach ache, closely observed after, at home, potentially with a second dose of epinephrine autoinjector or epinephrine that was administered, and they don't persist after this particular time period. All right, when is a clear recommendation to activate EMS? So you have signs and symptoms that emerge prior to epinephrine, it's not resolving, you've given both doses of epinephrine, and then you have any of these conditions present. So that's what we all can agree upon. I think here is where there is going to be, again, some art of practice that comes with different staff that you'll talk to. I will tell you my personal practice. Again, this is my personal practice outside of, recommendations that are going to come globally, but I've kind of follow what's outlined here. I do not require my particular patients to contact EMS after a first dose of epinephrine, but that's, again, my personal practice. Everybody's practice is going to vary, and I think we should not designate anybody's practice as right or wrong, because some of these come from our personal experience, some of these come from our interpretation of the data, and also some of these, more nuanced even than that, some of this comes from your relationship with the patient and what a patient is going to need in terms of under recognition or something like that in that particular situation. Knowing their baseline conditions, knowing if a patient has depression, anxiety, and are going to underreport theirs. It's a little bit more nuanced than that. So that's where I highly recommend have a spirited discussion with your staff, find what works for you, and figure out, what's going to work for you after you graduate AI fellowship. All right, considerations for and against home management of anaphylaxis is again discussed here. There is a shared decision-making process that could be considered in the pro, and then in against, you have, parents, caregivers are just bottom line not comfortable. Makes sense. Immediate access to two epinephrine auto-injector devices, whereas you have no availability or you only have access to one. All of these are outlined here, and so I won't go through every single one of these on the chart here, but these are all factors for you yourself to consider when you're making a decision for an individual patient on whether after a single dose of epinephrine or 2 doses of epinephrine, whether they go into the hospital or not. Okay, we talked about epinephrine dosing, and then in terms of the calculation for children for weight-based dosing, it's going to be 0.01 mg per kg that we do, again, especially if you're in that 7.5 or below and you don't feel comfortable prescribing an auto-injector device. Here's our dosing for antihistamines, for albuterol, additional corticosteroids, which we talked about the data for that, isotonic saline, as well as drugs to administer, especially if there's beta blockade patients or patients where beta blockade has occurred. Okay, how about indications for prolonged observation for anaphylaxis? So moderate to severe reaction, that can either be based on kind of your subjective diagnosis, or you can use a grade system to say what grade of anaphylaxis they had to determine, that. Need of multiple doses of epinephrine, I think that's a pretty clear one here. Episode in an asthmatic patient, pretty clear here that we talked about. Ingestion of antigen and possibility of continued absorption, and then previous history of a biphasic response. Biphasic anaphylaxis, so this is where you can have anaphylaxis that abates and then exhibits recrudescence after the initial symptoms disappear. The incidence can range from 0.4 to 15%, occurs within the first 6 hours after resolution, and then it can be as late as 72 hours. So, such events are more common when the inciting event is unknown or if there was initial hypotension. There's a delayed administration or underdosing of epinephrine, and then circling back to that point about corticosteroids. So there's 2 large separate meta-analyses that concluded that biphasic anaphylaxis is not suppressed by the use of corticosteroids. This is a chart that you can take with you for anaphylaxis education on your patients, as well as the staff, as well as the general public if you are, if you're doing any community-based approaches for anaphylaxis education. These are my references, and I will open up to questions now.